Hello everybody and welcome to another episode of Acute Medicine Shorts. This is number 4 in a series about venous thromboembolism assessment and prescription. These are brief tutorials that cover more practical aspects of acute medicine, which unfortunately you're unable to do more directly in this current climate. If there are any topics that you would like covered or any skills or topics that you think need covering, you're very welcome to email me. So in this tutorial today we're going to talk about the incidence of venous thromboembolism or VTE in hospitals, the pathophysiology, the assessment, the prescription of VTE prophylaxis and alternative methods. Let's start off with some good news. So this is data from NHS Digital, which looks at post-discharge venous thromboembolic deaths in England from 2007 to 2019. The good news being, as you can see, there is a nice 20.8% reduction since the outset. I think there are a number of reasons for that. We've paid more attention to venous thromboembolism. There are much stricter quality improvement guidelines, or these are otherwise known as CQIN, where trusts are audited against these things. CQC inspections look at VTE prophylaxis and management, for example, and so on and so on. So it's important that the death is reduced, but certainly we've not eliminated it yet. When we look at the incidence or rates of venous thromboembolism per 100,000 people, you can see that there is a marked increase in age after about 45 years. So certainly, particularly the frail elderly are most at risk of venous thromboembolism, and certainly it's important to bear in mind that if they got venous thromboembolism, then they are far more likely to experience the consequences of anticoagulation rather than someone a fraction of their age. So for example, significant head injury, frequent falls, hematoma of joints, subdural hematoma, and so on. So it's important that we try to do all we can to prevent VTE in people in the frail elderly especially, but of course all our patients. When we think about postoperative VTE and when we're assessing the risk, then again it's important to realise that surgery, particularly orthopaedic operations, are a significant source of VTE, and we'll look at this in a moment. And you can see that the relative time for a DVT develops since inpatient surgery tends to peak at about 3 and then slowly tails off. So it's a slightly skewed bell curve. When we look at the incidence of VTE associated by surgical procedures, you'll notice that the triple A has fluctuated rather a lot over the years and is on the increase again. And I think this reflects the fact that these patients who have things like AAAs are often significant vascular paths. So although they have aortic aneurysm, they may have peripheral vascular disease, which would make them more prone to VTE. Orthopedic operations, so my colleagues in orthopedics have paid attention to this. A lot of my orthopedic colleagues prescribe low molecular weight heparin perioperatively or low dose apixaban perioperatively to try and prevent VTE, which are slowly but surely starting to reduce the rates in orthopedic surgery. I've talked about this in more detail in the tutorial on pulmonary embolism, which is available on Moodle and YouTube, but basically remember Virchow's triad, which is a triad of stasis, endothelial damage or trauma and hypercoagulability, all three of these factors which will overlap to facilitate the development of a venous thromboembolism. Furthermore, when we look at the development of a blood clot, you can see in picture 1 that there has been perivalvular collection of red cells, which of course then become sticky, and in picture 2 you start to see the adhesion develop further, and then eventually the clot embolizes into the deep venous system or into the pulmonary system. When we think about venous thromboembolism in secondary care, it's a common complication still at about 1 to 2 per 1,000 per year. It's approximately that 2/3 are deep vein thrombosis and about 1/3 are pulmonary embolism, and roughly 30 to 40% of pulmonary emboli come from DVTs initially. DVT in pregnancy occurs at about a rate of 1 in 1,000 live births, and VTE in critical care has a near incidence of 40%. So this is the Royal Free Trust risk assessment for venous thromboembolism, and basically forms into 3 parts. So first of all, you want to assess if your patient is going to have significantly reduced mobility relative to their normal state. So again, it's important that, which you talked about elsewhere, about functional history. So if it's a yes, of course, you're then going to complete the risk assessment. If it's no, you're going to complete the risk assessment also. Now, what you'll find, however, is that, so if a patient comes in, let's say for a broken hand, very mobile, otherwise has no limitations on walking, you probably wouldn't need to prescribe him VTE prophylaxis for, say, an upper limb fracture, as the patient is perfectly mobile. Therefore, there is no significant reduction in their mobility, but you might prescribe them TEDs, for example, overnight. So part 2 then is to look at the medical and or surgical risk factors for thrombosis, and the third part is to look at the bleeding risk factors, and then essentially you're weighing up whether the risk of thrombosis outweighs the bleeding risk or vice versa. Let's have a quick look at the medical risk factors. So the most common ones that we tend to see, certainly in acute medicine, are of course significantly reduction. So that more or less encompasses all of our HACCP admissions, age over 60, multiple comorbidities, dehydration, cancer, previous VTE, and so on. So you can see that nearly encapsulates all medical patients that are admitted in one way or another. Surgical risk factors are a little bit more specific. So any surgery with significant reduction in mobility, such as orthopedic surgery, acute surgical admission with intra-abdominal or inflammatory condition, any anaesthesia and surgery involving the pelvis or lower limb, greater than 60-minute theatre time plus anaesthetic time, including total hip replacement, total knee, and total anaesthesia and surgery time of over 90 minutes. If there are none of the above on either of those risk factors, you simply tick. On bleeding risk factors, so you have active bleeding, so gastrointestinal hemorrhage, for example, or leaking aortic aneurysm, bleeding risks such as acute stroke, neurosurgery or lumbar puncture, uncontrolled hypertension, thrombocytopenia, and so on. So that's relatively uncommon compared to the risk factors. So on balance, this patient is going to need to have venous thromboembolism prophylaxis prescribed. Of course, you're going to sign and date it as you do all risk assessments and prescriptions. The main thrust of VTE prevention is to encourage mobilization, and again, this has really revolutionized how we look at elective surgery, particularly in orthopedics and colorectal surgery. So for example, you have what's called enhanced recovery, where the patients are mobilized much sooner, much quicker. PCAs are taken down much faster now, so that patients can mobilize quicker to avoid VTE and enhanced recovery. You want to avoid dehydration by prescribing suitable rehydration fluids. Again, this is covered in the IV fluids talk. You want to reassess for VTE whenever clinical changes condition, and VTE prophylaxis basically comes down into 2 categories. The first one is mechanical prophylaxis, and this is the TEDs, for example, or TED stockings, where you increase blood flow velocity to the legs and reduce venous stasis. So these can be static, such as the TEDs, or dynamic, where you have intermittent pneumatic compression. And then, of course, you can have anticoagulant prophylaxis, and at the Royal Free, we typically use Inhixa or enoxaparin. So these are just illustrations of what I mean by those 3 mechanisms. So you obviously have Inhixa at the top right. You've got the intermittent pneumatic compression devices, which you may have seen on some of the wards, things like vascular and other surgery, surgical wards particularly. They are more used than in medicine. And then, of course, you've got the TEDs at the bottom right. So when to avoid mechanical prophylaxis, so i.e. the TEDs or intermittent pneumatic compression devices. The list is on there, but in summary, peripheral arterial disease, bypass grafting, peripheral neuropathy, poor and damaged skin conditions such as ulcers, allergy, cardiac failure, lymphedema, deformity, stroke, and recent DVT. So when we do the prescription, again, this is a copy of the Royal Free Trust prescription chart. They will be markedly similar all across the various trusts that you will rotate into. Once you've done your VTE assessment, you've either decided that your patient can have low molecular heparin, for example, or they need mechanical devices. Obviously, if your patient is going to have low molecular heparin prescribed, of course, then you would just ignore the top box. So you can see there you've got your prescribing options where you prescribe them for both legs, possibly IPC and sign and date and so on. This is an example of prescribing Inhixa or enoxaparin, a typical dose being 40 milligrams, and that's prescribed subcutaneously once a day. It's historically timed at 6 o'clock in the evening, and I think that's a long-standing historical thing, as usually, of course, we used to use warfarin, and warfarin is still prescribed at 6 o'clock to this day, although actually one could argue it doesn't particularly matter. So I think that's probably in keeping with history, and also a lot of patients have their medications in the morning, so it balances out. As far as I'm aware, there are no clinical reasons for us to do it at 6 o'clock in the evening. So you've got your mechanical prescription at the top, anticoagulant at the second half of that page. You've also want to make sure, of course, you consult your trust protocols, and you may need to adjust the dose in renal impairment. So if they have low EGFR, then the dose will get reduced to 20 milligrams. And again, you suggest that you have a review of the BNF for whichever trust low molecular heparin use, and have a quick look at when you would do renal adjustment. If your patient, of course, has a bleeding risk, i.e. they're already on anticoagulation such as warfarin, apixaban, rivaroxaban, then you can see on here, this is our prescription chart here. Most of them are typically given twice a day. Certainly apixaban is either given at 5 milligrams or 2.5 milligrams twice a day. Dabigatran and rivaroxaban are both once a day. As you can see in the top half, we still use warfarin from time to time, and how you do that is will be discussed separately, but the prescription is there for you to see. And finally, just some resources on VTE. I did signpost you to the e-learning for health platform, which has multiple programs which will be suitable for all of you, including Acumen and Acute Medicine. There's a link to the program in venous thromboembolism and prevention. There's a website, VTE Matters, the NICE guidance on VTE prevention and management. And then there's a tutorial on YouTube and on Acute Medicine Moodle, which is by me on pulmonary embolism. Thank you very much for listening. Please like or subscribe to make sure that you are aware of new videos that are being produced. And of course, if you have any questions, you can contact me directly by email at any time, or you can use the Q&A section on Moodle if you have any questions. And I'd certainly encourage you to do that, because I'm sure if you have questions, other people will do as well. I hope you're all well. I miss seeing you all and look forward to seeing you again soon. Take care. Bye-bye.